My pleasure to introduce Dr. Ashish Parikh, the Chief Quality Officer of Summit CityMD, who will be speaking about the safety and efficacy of COVID-19 vaccines. Some of you may not be familiar with Summit CityMD, but really you are. You see, back in 2019, the Summit Medical Group that we all know so well merged with CityMD to form Summit CityMD. That merger permits the company to provide a full spectrum of primary and specialty care, along with more access points for urgent care. As I mentioned, Dr. Parikh is the Chief Quality Officer for the merged company. Prior to joining Summit CityMD, Dr. Parikh was the Senior Health and Quality Advisor at IBM in Armonk, New York. He also served on the faculty of the Internal Medicine Residency Program at St. Barnabas Medical Center in Livingston, New Jersey. Dr. Parikh is a fellow of the American College of Physicians and is board certified in internal medicine. Dr. Parikh will be available to answer your questions following the presentation, but as you formulate your questions, please keep them focused on today's topic. Any questions regarding your individual health concerns should obviously be directed to your own physician. Dr. Parikh, thank you so much for being with us today. The Zoom microphone and stage are yours.
Great, and thank you for giving me the time to talk to you all about this important situation with the vaccines for COVID-19. You know, unfortunately, we hit a grim milestone in the last couple of days of 500,000 deaths in America. So, you know, I do have a couple of silly slides in here, but I don't want to make light of any of the severe situation that we're in, not only the death and suffering for those families, but also everyone else who may have lost loved ones parallel to this from not going to the hospital for heart disease care or other things. So there's many more deaths related to this COVID pandemic than directly from COVID, and then all the suffering and long-term disability that folks are getting from the disease, as well as all the financial impact and issues with food and safety and everything else that has occurred because of this. So it is a terrible situation. I think currently it's a good news, bad news situation, which I'll go into, but did want to take a moment to acknowledge that it's tough for everyone. Real quickly, not to dwell on this, but Summit CityMD, as you noted, has expanded. We've been around for actually 102 years, and hope this merger with CityMD will give us a kind of footprint to give even more comprehensive coordinated care across the Metro New York area. And we do have a small Summit Summit Medical Group out in Oregon too. So if you're ever out in Bend, Oregon, you can always get great care there too. So let me start by just saying thanks for allowing me to expertise today. With COVID, it's a developing situation. I think that any one of us can be as much of an expert as anyone else because no one really knows more than anyone else, but I will be expertising, which is acting like an expert even when you're not one. I love this quote. It says, "It's when we realize that we know just a little bit more than about the subject than the person we're talking to, or worse yet, that we really don't know anymore, but the person is willing to believe we do." So thank you for allowing me to expertise for the next few minutes here. Secondly, the great philosopher Donald Rumsfeld said this, and I think it works perfectly for COVID, is that there are known knowns, right? There are things we know about this disease and we know about the vaccine, and we're learning more and more day by day. So it is changing quickly, but it is still really the tip of the iceberg. There are known unknowns. There are things that we know that we don't know about this disease, and I'll talk about some of those. And then the worst part of this is that there's stuff that's going to come up that we didn't even think about, right? That these are the unknown unknowns, and those are constantly going to be coming up with this. So I just wanted to put that out there too. And lastly, everything I have in here is rapidly evolving. So there's a expiration on most of this, particularly the numbers that I'll put out here. I put these slides together, made the final version on Saturday. So even already from there, things have changed. And so please, if you do use these slides, use them with a grain of salt, because really this talk should self-destruct in 2 days, like Mr. Phelps's emissions. So here's what I'm going to talk about. Basically, I'm going to go through kind of how vaccines work, just a real high level overview, and talk about how the currently available vaccines for COVID work, and then what we know about it, right? What we know is actually true and what we know are the myths. And then I'll go into a little bit about how our current situation with the disease itself is progressing, and particularly the impact of the vaccine in the US and then in our local region, and then talk about what does this mean for the future? What's going to happen in the next few months or next year or so? A lot of this is part of the known unknown and the unknown unknown, but we'll talk about that a little bit, and then I'll talk a bit about the vaccine, how it's being distributed, how you can access it, and some of that you may even, like I said, know better and be better experts than I am, and then hopefully we'll save some time for Q&A. So a little bit on vaccines themselves. So basically how any vaccine works, not just the COVID vaccine, is that you introduce a substance into your body that activates your immune system. Your immune system recognizes as something that should be in your body and activates your immune system so that when something similar shows up from a pathogen, your body will attack it and kill it. So you give little pieces, you give DNA, you give different things, dead particles from a pathogen. You inject any of those things, your immune system recognizes and now is ready, right? The army is primed so that when the actual pathogen comes into your body, you can knock it out. There's many ways vaccines are made. I picked these three because this is the kind of the front runners for the vaccines that are going to be available in the US over the next few months. The Moderna and Pfizer obviously are available already. They're what we call genetic vaccines. They take a tiny piece of the genetic material. In both of these cases, it's messenger RNA, but you can take DNA, and I won't go into the details of that. But basically, it's genetic code that gets put into your body. Your body recognizes, and that code is a blueprint to make the spike protein of the virus. And that spike protein gets made, and your body then recognizes it, activates the immune system against spike protein, so that if a virus with that spike protein gets in your body, you can kill it. Johnson & Johnson, which is going to go to the FDA in the next couple of weeks and most likely will get approved, is what we call a viral vector vaccine. So they take the shell of a different virus, remove all the stuff that can make that virus replicate, and again, put in the genetic material from the coronavirus. And in this case, again, what it does is it gets in your body, makes your body make particles that are similar to the virus. Your immune system recognizes them, activates so that when you get the virus, it can kill it. And lastly, Novavax is a vaccine that's now gone into phase 3 trials, and most likely will be the one that a couple months down the road, maybe the one that's next approved by the FDA for emergency use in the US. And that one works by actually directly injecting genetically engineered spike protein itself into your body, again, and same thing happens, activates your immune system so it recognizes it in the future. The mRNA vaccine in particular basically goes right into your muscle cell. And like I said, it's a blueprint, you don't have to worry about any of this stuff, but it makes these little spike proteins, and they either show up on the surface of your cell or get released into your bloodstream. And when they get released, these spike proteins activate two types of immune cells, B cells and T cells. The B cells then make antibodies. That's what we test for, and that's what we usually use as a surrogate for how immune you are. But it activates both types of cells that also develop memory. So once the infection goes away, these cells kind of float around your bloodstream, and if you ever see that spike protein again, they can reactivate and bring the National Guard out and activate them again. How long these memory cells last for this virus, we don't know. It's very variable depending on which vaccine we've used for other pathogens, and some of them last for life, some of them last short term. So we don't know what's going to happen with this one. Great. So real quickly on how good these vaccines are, you've all seen this data. Both the Pfizer BioNTech as well as the Mrna vaccine were tested in phase 2 trials in 30 to 40,000 patients. Half of them got the vaccine, half got the placebo. Neither the study people nor the participants knew who got what, so there was no bias in the data. And they found 94 to 95% effectiveness in preventing infection with symptoms. So that's the important thing I want to emphasize here, is that what they looked for was how many people got symptoms and a positive test. And it was 94 to 95% effective in that. But when you really look at how effective it was in preventing any severe disease, right? Sure, some people did get a little bit of symptoms, but out of the 70,000 people in these two trials combined, only one person in the Pfizer BioNTech vaccine arm actually got disease that was considered severe. And that person had an oxygen level of 93, so they were considered severe, but not even sick enough to go to the hospital and recovered pretty quickly. Nobody who got the vaccine in these two studies got severe symptoms bad enough to hospitalize them or cause them to die. So that's something that I think has been understated in the lay press, is that it's 99.99% effective in preventing severe disease, hospitalizations, and deaths. Obviously, when we get to millions of people, probably there will be some that will get severe disease, and maybe there might be even some that will die from the vaccine, even though they got the vaccine, but really highly, highly, highly effective. And the reason that's an important thing to remember is as these new vaccines come out, people might start vaccine shopping, say, oh, I want the 93, 94, 95% one effective one, not the one that's 89 or 63% effective. The J&J vaccine developed with Janssen, as well as the Novavax vaccine that's now, like I said, in phase 3 trials, are showing a little bit less effectiveness in terms of preventing infection with symptoms. But there's two things to caveats here. One is that they're studying them in other countries where there is these new variants, which I'll talk about in a minute. So had they studied the Pfizer and Moderna vaccines in those areas, they might not have been 93% effective, or during this time, they may not have been as effective. But again, the important thing here is with both of these vaccines so far in these studies, there has been no cases of hospitalization or death. So eventually, when it opens up, and for those of you or your loved ones or family members or friends who don't get into the current eligibility and get the vaccine later, and they may get a different vaccine, what you need to tell them is these vaccines are just as good, because the main goal here is to make sure that none of us gets really sick with permanent disability or dies from the vaccine. So just wanted to make that point there. In terms of safety, I think, again, most of you know all this, but based on these clinical trials, right, which had over 100,000 people, if you count all the trials, plus the 100 million people or more that have gotten the vaccine across the world over the last few months. Here are the things we do know about this vaccine. One is that it's safe for anyone over the age of 16, and which that doesn't mean it's not safe for people under the age of 16. It's just the fact that there's not enough placebo-controlled trial data to tell us that for sure. So again, a lot of times in the press, when we say something or scientists say something, people presume that what they're not saying is true, but it just means it hasn't been proven yet. In these trials, they had people with heart disease, with neurologic diseases, with blood diseases, kidney, liver disease, all kinds of diseases. So it's safe in people with chronic conditions also, hepatitis and HIV and all sorts of stuff. It's safe in people who have autoimmune diseases, rheumatoid arthritis and lupus. It's safe in people who have immunocompromising disorders or on medications that may suppress their immune system. Now, the immunity may not be as great in these people, right? But we know it's safe, and certainly the people with immune issues are more at risk, so certainly not a reason to not get the vaccine. Safe in people who have cancer, have had cancer, that are in active chemotherapy. There was a worry with injecting the muscle. Is it a danger for people on blood thinners? But again, not an issue, and okay to take even if you are on blood thinners. Again, it wasn't specifically studied in women who are pregnant or breastfeeding, but from what we've seen in the trials, people did get pregnant while they were in the trial, and now many pregnant women have gotten it. And based on extrapolating from the science on other vaccines and diseases, we think that it's very likely that it's safe in pregnancy as well as in breastfeeding women. And there's that additional benefit that it does the antibodies cross the placenta as well as get into breast milk. So actually the baby will get some passive immunity while those antibodies from the mom last in the baby. So there's that. And then lastly, like I said, it is now currently being studied in children 12 and older, and hopefully we'll have some data on that, so at least our high schoolers in the next phase or down the road can start getting vaccinated. Here's some myths that came out, particularly on social media, and some of them took a pretty strong foothold with the American populace, and I just want to make sure I clarify these. First of all, zero evidence or any scientific basis that it impacts fertility. This was something started by a couple of people and made it sound very scientific with antibody crossover and whatnot. But really, there's no basis of truth for the fact that it impacts fertility. And like I said, in the clinical trials, there were people who actually got pregnant while they were in the trials. It will not alter your DNA. That mRNA or DNA that comes in from the vaccine gets into the muscle. As soon as it does its job of translating the blueprint into spike protein, your body dissolves the vaccine very quickly. In particular, the Moderna and Pfizer vaccines, the only thing in there is the DNA, and there's a little shell of lipids. So there's really not much material, preservatives, anything else in there there that's going to last in your body, and it really is not going to mutate you or do anything else to your DNA long term. And there's no COVID virus in there. There's zero chance of the vaccine itself giving you virus, or you giving virus to your friends or loved ones by getting the vaccine itself. So there are some other vaccines that are live vaccines where if you take it, you may want to stay away from people who have immune disease because they can catch it. But COVID-19 vaccines do not cause any risk of virus to you or to loved ones around you. And then the last kind of fallacy, like I said, that came out was the fact that the vaccine does not prevent asymptomatic spread to others, right? The others, even though you're protected, you can give it to others. We don't know for 100% fact that it does protect you from giving it to others, but scientifically speaking, and if you just think of it logically, if far more people are getting the infection and symptoms, far less likely that you have the virus in you and far less likely you're going to give people the infection. So when you extrapolate the logic, really most likely getting the vaccine not only protects you, but protects everyone around you, because you're very much less likely to have the virus in you at all. Again, that's being studied right now, and we're seeing that maybe not 100% prevention of asymptomatic spread, but very likely it reduces it significantly. And then the risks, right? The risks are certainly far less than the benefits, right? The vaccine is known to kill people. It's known to cause chronic disability. Even if people have mild infections, we're now finding a significant significant percentage have these terrible symptoms called they're called long haulers, where they get dizziness and migraines and fatigue and things that are very tough to diagnose and manage. And so really, as many people we can prevent from getting the infection, better off we'll be. And the risks, we hear a lot about anaphylaxis. It's probably no worse than it is or no more common than it is for the flu vaccine, now that millions of people have had it. It's at a rate of about 2 to 11 cases per million doses given. A little bit higher in the Pfizer than the Mrna, but again, negligible in terms of when you get to statistical level or for you individually. And that's why we make you wait 15 minutes after you get the shot, because most likely if you are going to get some sort of CS reaction, it'll be within 15 minutes. They can be treated fully, right? It can be treated and reversible, as opposed to COVID, which we know can't be 100% reversible. The most common things that people get are fevers, chills, swollen lymph nodes on the side of the injections. If you got the injection in this arm, you may feel some swollen nodes in your armpit or in your neck, muscle aches, kind of just feeling flu-like and crummy. This is more common in younger folks. My parents got the vaccine and didn't feel anything after the second dose. I felt terrible, as did my wife. The reactogenic symptoms are more common after the second dose, because your immune system is activated and primed, and so it's more active after the second dose. But most of these symptoms are short acting and only last 24 hours or so. The opposite, some people think, oh my God, I didn't get a reaction. Does that mean I didn't get the immunity? That's not true. There are only a certain percent of people get these symptoms. So you got the shot and you just get a little bit of soreness and it goes away. Doesn't mean it was not effective in you. And then now we're seeing with now 50, 60 million doses being given out in America, we are seeing a couple of cases where people are getting other viruses like shingles or Bell's palsy, which can be caused by other viruses reactivating. Now, we don't know if that would have happened anyway, or if it's because your immune system is so revved up, but that is something that they're looking at. But again, these things that can happen are usually mild and reversible issues. So again, not a reason to not get the vaccine. And one other interesting thing I just want to make sure you guys are all aware of, in case you get the Mrna vaccine particularly, but it can happen with both, is 1 to 2 weeks later, you may end up with a big red swollen welt in the arm where you got the shot. And people get nervous that it was just an infection and cellulitis and things of that sort. This is a normal, expected reaction, happens in a small percent of people, and we don't know why, but most likely it's just that spike protein gets attached to the antibody, and then some of that gets deposited in this area and just irritates the area. It's not an infection, doesn't need management with antibiotics. Good idea to just make sure you show it to your provider so they can follow it. We do recommend that you kind of mark it off so that if it does start spreading, you can then get more medical attention, make sure you don't need any treatment for it. And so for a vast majority of us, when we get eligible, we really should go out and get the vaccine because it works. It's going to help you. It's going to help everyone around you in terms of your loved ones, and it's going to really help the general population to get this under control. Here's a few cases where you should probably think about delaying the vaccine. Obviously, if you just got COVID, you don't want to get the vaccine for the 10 days that you should be in isolation. Because you don't want to go out and spread the virus to the other folks getting vaccine or the healthcare workers who are vaccinating. And the second is that you're already feeling sick and it may activate your immune system. We don't know if it can interact and cause other issues. And obviously you want to wait till your COVID-19 symptoms are resolved. So don't wait just a minimum of 10 days, but until you feel all better if you're going and get the vaccination. Some people say you can, or you can certainly wait up to 90 days after you've had the COVID infection because you're going to be immune from the native infection itself. But after you've resolved the symptoms and 10 days have passed, you can certainly go in and get the vaccine to get the prolonged immunity that we think we'll get from the vaccine. If you're in quarantine, let's say you got exposed to someone with COVID, you really shouldn't come in and be walking around and exposing yourself to other people to make them sick. So if you have potential for getting infected or in quarantine, please don't come out to get the vaccine, delay your appointment. If you had COVID and you were treated with one of these antibody cocktails made by Eli Lilly or Regeneron, you should wait 90 days because again, you're immune for 90 days and having that artificial antibody in your body may reduce the effectiveness of the vaccine. So wait 90 days and then get your vaccine. If you've had any other vaccine in the last 2 weeks, your flu shot, tetanus shot, anything like that, you should probably not get the vaccine again, mainly because we don't know if there might be some interaction and reduced immunity. We don't know for sure, but just to be safe, if you've had any vaccines, wait 2 weeks to get your COVID vaccine. And if you got the COVID vaccine, wait till you get the second dose, wait at least 2 weeks before you get any other vaccines after that. And lastly, if you're feeling crummy in any other way acutely, might as well wait till you feel better before you get the vaccine because one is if you feel worse, you're not going to know whether it's COVID, whether it's the shot, whether it's whatever your underlying illness is. And again, for the risk of not spreading potential COVID to others. So good idea to just wait and delay your appointment if you feel unwell. So that's kind of the basics on the vaccine. So where are we at with COVID right now and how is the vaccine impacting this? So this is the blue line here is New Jersey and the orange line is the US in general. As we all know, New Jersey and New York saw that terrible peak in April and May. We were the epicenter for the US with these issues. The US itself actually saw its worst peak in July and August, right? When it spread across the country and the rates were rising everywhere, while we were actually enjoying a kind of a period of a little bit of quietness here. And then we had the terrible peak in late December that got really bad in January with lots of infections, lots of hospitalizations, ICU deaths, places like California running out of oxygen and hospital beds and all the terrible stories we saw. And the good news is we're now on the downturn from that, right? So the nice thing to see is that there's a rapid, steep decline. The Metro New York, New Jersey area isn't enjoying as much of a steep decline. And again, that might be one of the unknowns, but there are multiple factors here. But a couple things I want to point out here is that even though there's a steep decline, the current rate of new cases is just reaching the worst peak we had back in August. All right, so it's getting better, but we're not out of the woods, and we shouldn't be out there, doing victory laps at this time. We still got to keep our vigilance so we can see that decline continue to go down. Most likely reasons for this decline. One is that I think that after the kind of fatigue and exhaustion we had in December, and people started maybe laying their guard down and gathering with loved ones or family members or something, I think we've kind of also now come back to the fact that we do need to continue to mask. We need to continue to stay away from others. We need to continue to avoid gathering if we don't have to. So I think those habits have helped. The vaccinations certainly have helped with 50, 60 million people now having had at least one dose. And the third thing is that, 30 million people that we know of in the US have had COVID already, and that's by testing. So most likely in reality, there's probably 3 times that many people have actually had COVID in our country. So 100 million people have already had COVID. You add a few million more that have had the vaccine. So 1/3 of the country is likely immune at this moment. So the vaccine is having a harder time spreading, right? Because 1 out of 3 people in between is not going to catch it and give it to others. And so all those things are probably leading to that downturn. Now we can keep our fingers crossed that we can keep being good, keep vaccinating, and keep the vaccine at bay. The virus at bay. We'll hopefully see that continue to go down. Here's the death rates. Again, mainly I put this out there. Orange is USA, blue is New Jersey. Death rates per 100,000. The reason I put this out there is that, again, the decline in that is slow. It's still very high, and we cannot give up our vigilance. We don't want to get to the point where we suddenly see an up spike and our hospitals get full and we can't take over our really sick patients, and we end up with more death. So vigilance still needed. I just want to point out at the bottom of this, like I said, you're all experts on this. I've put the sources for most of these slides, so you're welcome to go and look. There's some great data out there, and you can learn more about it yourself. So all this out there, in particular, because these numbers will change regularly. Here's our vaccination rates, and I apologize, I don't know if you can see this little bar up here. I don't know how to hide it, but anyway, so I don't know if you can see the title of my slides here, but this is the vaccination rate in the US. And again, this was on Saturday, and there was a little bit of disruption because of all the snowstorms. So we did slow down a little bit in the last few days, but hopefully we'll start catching up again. Here's New Jersey's rates. And so, close to 10 or 11 million, 10 million people in New Jersey, give or take. We're at a vaccination rate already of 10 to 12%. So good news, and we got to keep that up. The one thing I do want to point out is that we really need to focus on vaccine equality and access to the vaccine here. We always focus on vaccine hesitancy and what to tell people who don't want the vaccine. I think the other thing we have to focus on is how can we get the vaccine into underserved areas where people don't have insurance, people don't have the tech savviness to figure out how to register, people have transportation issues. Because if we don't get everyone vaccinated, particularly high-risk populations vaccinated across the state, across the country, we will continue to see spread of the disease and put us at risk, and we'll continue to see death and disability. So really got to focus on both of those things, and that of course falls not on only on the government and the population, but also on us healthcare givers. Now, and then, like I said, the good news is that we're on the downturn. The vaccinations are working, but this is a race against the variants, right? The variants, as you can from this poltergeist slide, hopefully if any of you have seen the movie, they're here, right? We just in the U.S. we were behind on tracking variants, but this is what the official prevalence of the variants is by state. The UK variant first, the South African variant second, and there's this new Japanese variant that we're now tracking. It's only being seen in a few states, but that's because we're only testing it here and there. Most likely these variants are out there, and there's no way to really stop them from continuing to spread other than our good habits. But what do we know about these variants? Again, there's a lot of known knowns and a lot of known unknowns, and probably a lot of stuff that's unknown about this. The main thing we know about this, particularly the South African variant, is that it spreads more easily, right? So for example, we've kind of made up this rule that if you're more than 6 feet apart and you're near that person for less than 15 minutes, most likely you're not going to catch the virus. That's not a hard and fast rule, right? So that's why we want to always wear masks as much as possible. But it could be that this new virus, you're close to someone for only 10 minutes, and you may, and you may catch the virus, or 5 minutes, or you may be 8 feet apart as opposed to 6 feet and still catch the virus. So again, my point here is that you got to keep being vigilant about the masking, avoiding sharing air with anybody else, right? So other than people in your household, you're going to be around anybody else, whether it's at work, in the shopping center, in the mall, your neighbors, your friends. Wear your mask at all times. If you wear your mask and the other person is wearing their mask, no matter how contagious that vaccine is, it's very unlikely to get to you. One of the things that puts us at biggest risk is when we share meals or drinks or stuff, because that's when you got to take your mask off and you can't do anything about it. So that's my personal opinion. I think a lot of healthcare professionals is that minimize taking your mask off around other people who you don't live with, and will really negate a lot of the contagiousness of these new variants. The one good news so far is that they're not more virulent, meaning they don't make people sicker. We haven't seen that these variants lead to, if you get infected, more likely to cause hospitalizations or more likely to cause death. So again, if we keep the spread at bay, we're not going to see more death from this. What about the vaccines? Do they work against these new variants? The data out there is very sparse and very early, but here's some of the things we know. The Mrna and Pfizer vaccine in kind of looking at when it was given in certain places like the UK, looks like it may be less effective against particularly the South African variant, meaning that if you got the vaccine, instead of being 95% effective, you may be more likely to catch the virus. And again, probably this has to do with people who got the vaccine letting their guard down. We have seen with the AstraZeneca vaccine, particularly in the study, that was significantly less effective in preventing symptomatic infection to the South African variant. South Africa decided not to approve the vaccine. The WHO did approve the vaccine. And why is this? Because these vaccines, even though they may be less likely to have you get symptomatic disease, still show that there's a significant less hospitalization and death if you get the vaccine, right? That's what's most important again to us. With the new ones, the Novavax and the J&J vaccine, they actually have, the Moderna and Pfizer weren't studied on these variants, while these were, and they do show reduced effectiveness against these variants. But again, a lot of times what we're checking for is also the antibody response, right? How much antibody did you get? And there are other, like I mentioned earlier, ways that your immune system works. And so looking at immunity just by looking at antibody response isn't 100% give you the full picture. Again, my point being, vaccines are still effective, and any vaccine you get is good because it's going to significantly reduce your risk for getting severe disease and hospitalization. And the second thing is, just because you got the vaccine doesn't mean you should let your guard down with all your smart behaviors. It means you should be less nervous and you can enjoy going out and maybe seeing your loved ones a little bit, but keep your mask on as much as possible. So the final thing with this is you've got this race against the variants. You've got the race against time to get the vaccine to everyone. When will things return to normal? Will that decline continue? Will we get to a herd immunity, and will things get better? What it is it's a race between the good factors and the bad factors. The good factors being the fact that the new cases are falling rapidly. Sorry for the typo there. That's new cases. The R naught rate, which means that for everyone who gets infected, how many new people get infected? When we were on that rapid rise in terms of the peak in December, for every new case, there was 1.2 to 1.4 people getting infected and new cases coming up. That's now below 1, so that for every infection, the new rate is less than 1, which means it's not spreading as fast. Good news. So if we can keep that up, that's great. Vaccinations are working. 100 million people, like I said, are probably immune from the infection, from getting the infection itself, and our good habits. That's going to race against the fact that vaccine distribution has had disruptions, right? The manufacturers were supposed to each give us 200 million doses by the end of January. That didn't occur, although they are pumping out a lot of doses. And then, Moderna, for example, is made in Mississippi, is then taken over to the FedEx headquarters in Memphis and then flown all over the world, and particularly over the country. That all got disrupted last week with the crazy ice storms and snowstorms. So all of those things can slow down vaccination rates, which gives the virus a step ahead of us. And then these variants. So far, the variants aren't causing more death and virulence. And also, it seems like the vaccines are, even though I gave you some mixed data, are for the most part working to prevent severe disease. But if it turns out there's a new variant that is more virulent, that could make change that curve. And again, last thing is how well we stay vigilant with all of our good behaviors, right? So this is I put the source at the bottom. This was a beautiful article in the New York Times, which really talked about this. And this is basically the rate at which we'll get to herd immunity if we continue at our current pace of 1 to 1.7 million people getting vaccinated daily, as well as the current rate of infectivity of the variants, and our current behaviors in terms of mandates to keep masking, in terms of limiting restaurants and arenas and gatherings, all that stuff. If we continue on this pace, you'll have the red line is how many people will get vaccinated over time, and the orange line is how many people are immune, including vaccination plus people who already got the disease. And so unfortunately, people will continue to get sick. Some people continue to die, but we can bend that curve. And hopefully between the two, we can get to a herd immunity by July. Would be a very nice case scenario with unfortunately more deaths, but hopefully slowing it down and more people getting the vaccine. This is if we increase that rate of vaccination from 1 or 1.5, 1.7 that we're at right now to 3 million per day. Is that feasible? I don't know. It's possible, especially with the J&J vaccine coming out, if they were able to pump out a lot more. If we could speed up that rate to 3 million a day, we're going to increase this curve, right? We're going to get more people vaccinated more quickly. Hopefully that means there's less people available to get infected, so that curve bends, and we can get to herd immunity by May. That would be a great case scenario. And this is an ideal case scenario, which I don't think will happen. But if we get to 5 million vaccinations per day, we're going to get people really quickly immune through vaccination, and we could get herd immunity by April. Again, this would be, best case scenario. I don't think it's going to happen, but something that we can aim for. Now, going back to current status, right? This is where we reached vaccination in July. If we continue our current habits and our current vaccination rates, and the variants don't impact us significantly. But in that time, by the time we get herd immunity, unfortunately, we're going to have 100,000 more deaths, and give or take, right? These are all very rough estimates. But if we were to stop our good habits or loosen some of our distancing requirements, some of our restaurant requirements, sporting and arenas and all of that stuff. Again, I'm not advocating one or the other, but I'm just saying that if we start doing some of that, you're going to start spreading it a little bit more quickly. If when our vaccination rates across the US get to 15%, if we loosen some of our masking and distancing requirements, you're going to see a quicker rate of infection of people. And herd immunity of July, we'll reach it in June, but it's because more people got infected. Unfortunately, there'll be 170,000 additional deaths instead of 100,000. So more people will die, even though we'll get to herd immunity quicker. And if today we just said, okay, let's remove some of these restrictions and loosen up our mandates, we can reach herd immunity very quickly, right? But it's unfortunate because a lot more people will get infected with another 320,000 deaths. So point being that we want to increase vaccination without losing our vigilance. And the last thing I'll talk about is contagiousness of the viruses themselves. So again, baseline, if everything stays the same, we'll be hitting herd immunity in July. If the virus gets more contagious, there are some people that are not having good behaviors, and the vaccine will spread. And so we'll, again, get to herd immunity a little more quickly, but we'll have more deaths. And if we had this worst case scenario of getting more contagious variants, at the same time we start loosening all of our guidelines and gathering more and loosening masking and all that, we could end up with herd immunity very quickly again, but at a huge toll in terms of people getting sick and dying. So hope I'm not beating the point in there too much, but I think we really gotta, if we want to get to herd immunity quickly, we've got to continue our good behaviors. We've got to keep optimizing how many people get the vaccine, the highest risk people getting the vaccine first, equity in vaccine, making sure that people are willing to take the vaccine, and then keep our vigilance up to keep these new strains at bay. And then we can reach a normality again. But that normal, most likely, in my opinion, this is a prediction on a personal basis, that new normal will never be the old normal, right? I think there will be situations where we'll wear a mask even once this virus gets completely under control. I think if you're going to go walk around the airport, wear your mask, right? Some of the things we see in the Asian countries, I think will be something that would be smart for us to continue doing. If you ever feel a little bit ill for whatever reason, fever, you wear your mask and you try not to go out, and things of that sort. I think during flu season, you'll see a lot of people wearing their mask regularly in the future. But I think hopefully at least we can get to the point where we're not fearful to meet each other and get together, and that can happen based on these factors that I talked about. What we don't know, which can impact all of these curves and when we're going to get there, is some other things like how long does immunity last, right? So right now we know for sure about 3 months and probably even longer if you've gotten the infection, 3 months and probably even longer if you've gotten the vaccine, but we only know the data that far out really. So we're going to learn more as time goes along, and hopefully these vaccines keep you immune for a long time, or hopefully if you've had the infection, you're immune for a long time. But again, we just don't know about this stuff. Part of it has to do with the way your immune system works. Part of it has to do with these mutations, right? Most of these mutations have not impacted that spike protein enough so that your antibodies that you make still go and kill it. But if suddenly that spike protein becomes very different, you may lose complete immunity. Again, not to scare everyone, but that could happen sometime in the future. And so you could lose immunity and the last thing is, who knows what can happen in a manufacturing plant? They have a disruption because of a breakdown of a part, or the materials aren't available, or we get a terrible snowstorm or hurricane or something. That could all impact all of this also. So a lot of things still unknown. So bottom line, we should all try to get the vaccine when it's available. We should all still be smart about our good behaviors. So now that the vaccine is available, how should you get it? Again, I'm not the expert on this. I can just tell you what I know and what we know from our distribution at Summit Medical Group. Here's what we know. All the vaccines that are manufactured are owned by the US. Summit Medical Group can't go out and purchase it like we do the flu shot. No hospital, nobody else can go out and get it and offer it to our patients. So the government controls the vaccine. They control how much they distribute. And usually for the majority of it, they've been distributing it directly to the state and local health departments. That's the only way that the vaccine is being sent out there for now, as far as I know. The state health department then gets it and then divvies it up amongst all the vaccination sites, again, to the best of their ability to try to make the access as much as possible and to keep it as equitable as possible. And the state decides which vaccine you get. So this is mainly to let you know, so that these mega sites, the hospitals where you're vaccinating, the local vaccination sites, places like Summit Medical Group, we don't control any of this stuff. We try to predict how much we're going to get from the state, but they sometimes goes half of what we ask for, and so we have more appointments than we predicted, and you have to cancel. So please be patient with all this stuff. No one is doing any of this stuff to try to make life difficult. But there are a lot of difficulties in here to try to optimize things. And then, like I said, there's all these other impacts that are factors that are well outside even the state and local vaccination control. And then the biggest problem, I think, that what happened was that the rollout, no fault of the state. I mean, they had to do what they thought was best. But when they opened up the vaccination to all the high risk criteria, basically half the state is now eligible for the vaccine, right? So 4.5 million, 5 million people in New Jersey are now eligible for the vaccine. And certainly we know that's going to take a long time to get through. So so just even expand to other groups is going to be a while. Some people think that if we had slowly expanded by age maybe, or only a couple of chronic conditions at a time, we'd have gotten people in a more controlled fashion. We'd have less people jumping the line. Right now, there's a chance you can just say you're a smoker and get in. And maybe that would have been better. Again, a backseat or Monday morning quarterbacking on some of this stuff. But the fact of the matter is right now, these are the folks who are eligible, and this is publicly available on the New Jersey websites. But because of this, there's far, far more people eligible than there is vaccine availability and appointment availability. The main thing that is good is that cost is not an issue, right? The Cures Act has made it very clear that nobody can charge some individual for the vaccine. The government obviously is covering the cost of the doses themselves. So the vaccinators like Summit Medical Group, the departments of health, the hospitals don't have to pay for the vaccine, so we don't charge the patients. And we can charge, if you have insurance, we may charge your insurance company for the vaccination itself, because obviously all the vaccinators have to put resources into getting people vaccinated. So we can charge your insurance company for the administration fee. But if you don't have insurance, or if it's not covered, we cannot balance bill the individual. So it's great. You should never worry about cost, copay, any of that impacting this. And if you are charged by any of your vaccinators, you should really make sure you call them up and clarify that. There should be no bill to you at all. So how do you get the vaccine? Again, I'm not the expert on this. There's a lot of resources out there that tell you different things to do. But I would say is don't rely on one source, right? Go to multiple sources and try to register yourself everywhere possible. So there's the New Jersey registration that you should go to and register. Secondly, the New Jersey, from that site, you can get to a list of all the places that are vaccinating. A lot of these have online registration, so you should go in and register yourself on all of these, or as far as you're willing to or able to drive. Get out there and get yourself signed up for this. And now the commercial pharmacies are in the business, so make sure you're looking at those sites also to see where you can get vaccinated. For example, on the CVS website, the way to go there is not to, you should obviously register, but you should look at New Jersey and see where it's available. And suddenly you may see that it's available in Union. So most of the time when you go in, you keep looking at this, it'll say no doses available, but it may suddenly appear. Robert Wood Johnson, Atlantic Hospital System, Meridian Hackensack System, go and register in all those places because you never know when your turn will come up. And then, like I said, the distribution is uneven. So the Robert Wood Johnson Barnabas may get 10,000 vaccines this week. So they open up a bunch of appointments. Next week, they may only get 2,000 if they don't open up new appointments. But the following week, suddenly get a large dose. So just because they don't have appointments today doesn't mean they don't have appointments tomorrow. Again, this gets very difficult if you're not tech savvy, but if you can do things where you keep looking at availability, you'll get in more quickly. And there's a lot of resources out there, which, again, I'm not even the expert on social media, but Facebook apparently has the site, the New Jersey COVID vaccine info site, has all those sites I listed on that are on the state side, but has all this detailed information of when you should click, right? For example, the Atlantic City mega site, the Atlantic County mega site, they've published dates, times each week. For example, Saturday morning at 8 a.m., if you go and log on at that moment, you'll get a random number for everybody who's logged on at that moment. And if you're in that first, whatever, couple thousand people, you'll get an appointment, right? But you need to know that. So this Facebook site apparently has this nice spreadsheet. It's updated regularly and tells you all this kind of stuff. I don't know how to use Facebook, but if you do, or if your friends do, ask them to look at this site. I don't know if you can read this here, but it says vaccinateny.org up here. That's another crowdsourced site set up by Good Samaritans. Again, tells you details of where there's availability, how you log on, all this kind of stuff. So there's lots of things out there that can help you, but you really got to be a little bit savvy to do this. And that's why I think it's up to us as public health workers and health care providers to really make sure that we can try to get access to people who are not as savvy, don't have the resources to do all these things. And then real quickly, I'll end on what you can and cannot do if you do get vaccinated, right? So first of all, these are the things that are known about once you get the vaccine. We know that after you get the first dose, you're not fully immunized, so don't change anything. After the second dose, you have to wait about 2 weeks to make sure you get full impact of the immunity. Once you're 2 weeks out, you can feel a little bit more comfortable that you're immune and you're less likely to get the infection, right? That's when I would breathe a sigh of relief. I would continue to wear my mask. I would still avoid sharing air with anyone I don't live with, right? So I'd wear my mask. I'd avoid crowds. I'd avoid unnecessary gatherings when I don't need to. But if I hadn't seen my grandma in 2 months, I'd wear my mask and I'd go see her. I'd stay away from. I'd hold my breath and give her a hug even. But I'd then sit 6 to 8 feet away from her, talk to her. I'd try to keep the windows open if I could, keep the place ventilated. I'd probably avoid not eating a meal with her because then she would have to take her mask off and I would too. But I would feel less anxious about this, right? So you can consider loosening some of that stuff. But again, to me, taking the mask off is when you're really increasing that risk. And again, you should feel more comfortable doing it, but avoid it where you don't need to do it. Right, so this has got the usual stuff that you would want to see, and I'll give you these slides. I won't go through every bullet here. Some of the other questions you guys had sent to me, I wanted to just quickly go over. Is how is this new these new variants going to affect immunity? And we did go over this a little bit, but basically, I'm sorry. Let me see here. This is how would not getting the second shot affect your immunity. So there's growing body of evidence that getting that one shot may be good enough, right? When we look at immunity after the first shot, we're only looking at it at 3 to 4 weeks because that's when you get the second shot in these trials. But what they found is people only got one shot and then somehow didn't get the second shot. There is some pretty good effectiveness, probably 50% or greater. And again, that's for getting any symptoms. And likelihood is that in terms of getting hospitalized or really sick or dying is probably might be even better than that. But you should still make every effort to get that second dose because that really is going to give you that full immunity and give you prolonged immunity, right? If for some reason you got sick in between, you had car trouble, snow, CDC has said that you're up to waiting up to 6 weeks, not a problem for that second dose at all with either the Moderna or the Pfizer vaccine. And most likely from our knowledge on other vaccines, if you had to wait a little bit longer, it's not the end of the road and it probably still will give you that full benefit. But I really would try to make sure you don't avoid doing it. But for some reason they got canceled and they put you out 7 weeks, don't get too stressed out about this. And interesting with the AstraZeneca vaccine, that this new trial actually showed that maybe going out 12 weeks for the second dose may even be better than giving it at 4 weeks. This is all stuff that's known unknowns, it's being studied right now. Can you mix, if you got the Pfizer at a site, now the site is shut down and the only place you can get is the second dose is the Mrna. If you had to do it, do it. But if you don't have to do it, I try to get the same vaccine, because again, that's what's been studied, that's what the best evidence is. But most likely, it's particularly the Pfizer Mrna, they're very similar. So if you, for uncontrolled circumstances, if you had to mix the two manufacturers, it's probably okay. We don't know for sure, but it's probably okay. Will the vaccine prevent you from spreading the infection to others? My answer is yes. We don't know how much, right? We don't know if it's 100%, if it's 50%, but if you get the vaccine, you're much less likely to spread it, because one is that you're less likely to get it. If you do get it, you're gonna have less virus in you. If the person who catches it from you with your low viral load will probably get less virus in them, and they'll likely get less sick. So I feel pretty comfortable saying that the vaccine is not only to help reduce your risk of being ill, but it's to help reduce the risk of not getting everyone around you ill. But again, you're going to say, well, I'm really contradictory. You still want me to wear my mask when I go visit my loved ones. We don't know 100%, and we want to use all our armamentarium to keep the spread down. So take the vaccine and keep distancing and wearing your mask. What will happen with these mutations, right? We know, what we do know is these mutations have been going on since day one, right? Since the first human got infected, probably minor mutations have been coming on. Some of those mutations will last and they die out because they didn't spread to someone else. Some of them spread but don't cause any consequences. Some of them spread and we have consequences that they're more infectious at this point. So the good news is that Pfizer and Moderna already thought of this. These scientists are very smart. One is that they attack the spike protein, which has far less mutations than other parts of the virus. So that's why they chose the spike protein to attack. Second is that they've already figured out how to tweak this. And this happens with all vaccines. As you know, vaccines over time, whether it's the measles vaccine or the flu vaccine, they tweak them to make them more and more effective. So this is not new and it will happen. What we don't know is how long, if you got this vaccine, how long will the immunity last and how often will you need the tweaked or booster or something like that. I wouldn't be surprised if we all end up getting the COVID vaccine seasonally at some point. But it may all completely die and we may not need it at all, or we may find out that one vaccine gives you a significantly longer immunity. You just need a booster like the tetanus shot. We'll see, unknown. Bottom line here is that the situation is evolving, but the vaccine is a key to this. If you have eligibility, you should go and get it. If you're not eligible yet, or if you're very low risk, you're at home, you're really not going anywhere, and you're pretty healthy, maybe you want to, maybe not for this group, but if you're younger, maybe you want to delay it, and so that other people at high risk can get it. But as soon as you're eligible, go ahead and get it, and then continue to be smart about avoiding sharing the air with others until we really have this vaccine under good control. Don't go out when you're sick. Avoid people who are sick. Wear your masks. And the last thing we know is that there are unknown unknowns, right? There's many things out there that we haven't even thought about that will happen with the situation. So stay vigilant, stay persistent, stay flexible. But the good news is there is light at the end of the tunnel. Hang in there. Whether you feel it or not, this has taken a mental toll on all of us. And so we need that positive news. I hope I didn't give you all just doom and gloom. It will continue to get better. So I'll stop at that point and see if there's some time for questions.
Okay, we'll start off with questions and we'll hit Mitch first. But before we do that, just remember, keep your questions related to the talk. We don't want questions that are specifically to you. And if you have specific war stories, you can tell them at the lunch meetings on Wednesday or Thursday. So with that in mind, Mitch, why don't you take the first question?
Thanks for informing us, enlightening us, and generally getting us smarter this morning. My question is, getting the vaccine out, in fact, getting 2 of them out in less than a year has been characterized as nothing short of a miracle. And my question is, did we just get lucky on this, or is it because the scientists and the technologies are all that much better than they have been with prior needs for vaccines?
A great question. It's probably a confluence of multiple things. One is that we were already working on vaccines for similar viruses, right? So there's SARS and MERS, which are very similar. So there were already groups out there, Moderna being one of them, that was working on these mRNA technologies for very similar vaccines. So they just had to kind of change it a little bit to get to this vaccine. Technology has gotten a lot better, right? So with the ways that we can replicate DNA and make more virus to study it, and the number of copies, all that has gotten significantly better in the last couple of decades. And then lastly is that the concerted world effort and the amount of money and resources thrown onto this has helped to speed it up. So it's probably a combination of all of those things together. But I agree with you. It is a miracle of modern science. And I think that we've gotten out there a safe and effective vaccine in record time that usually takes decades to do.
Thanks.
Mark?
Yes, my question is about herd immunity. You know, everybody talks about reaching herd immunity, but is there a way of stating the degree of herd immunity? And part of that question is, you know, it's well known that in some parts of the country, people are more willing to be vaccinated than in other parts. So if there are regions that have not reached herd immunity, do we have a way of rating it or assessing it for our location? So, you know, what should I think in New Jersey if people in Wyoming are not having herd immunity? And in New Jersey, we say we are, but people are traveling all the time.
Yeah, great question. And there's probably multiple factors in this, but let's say we're all great citizens and we get to 90% vaccination rate in New Jersey. And the 10% who didn't get it or didn't get it for a legit reason, they had allergic reactions or whatever the reason was. We know that if someone from Wyoming comes here and has the infection, really the only people who are at risk for getting it is that 10% who aren't immune, right? So unfortunately, those people are still going to be at risk, but it's not going to cause a major outbreak in Summit or in Berkeley Heights because the majority of us will be immune. So your cousin who couldn't get the vaccine may get sick, but he's not going to give it to anyone else. The person from Wyoming isn't going to give it to anyone else because we're immune. So we won't get major outbreaks, and you can start feeling comfortable that in regions where we have good vaccine acceptance and good immunity, that we won't get major outbreaks. But this is the reason we want to get equity, right? We need to make sure that the folks who don't have insurance, the folks who have poor socioeconomic, don't have the technology and the resources to get out and get vaccine, we go out and give it to them because that is our local folks who will impact our local outbreaks. And then the second thing is, you know, there's this vaccine nationalism. So if you think of it on a broader sense, we really want to work to try to get the vaccine out to the world because, again, it is a global situation. And until we get to herd immunity, if we don't, if people keep traveling and they're not getting vaccinated, it's harder for us to control the virus. So we've seen this with measles, right? There's areas where people are refusing the measles vaccine, and we've seen kids getting very, very sick. But the outbreaks are local in areas where people don't get the vaccine, while in areas where there's high vaccination rates, there aren't outbreaks. Hope I answered your question.
Bill Tittle?
Yeah, thank you very much for the talk. I understand you can't predict when we're going to need booster shots, but how does the science go about determining when we will need a booster shot?
Again, multiple factors, and I'm not the expert on this, but I'll tell you what I understand. One is that we will be able to continue to check antibody levels, right? So right now, I got vaccinated, or people in the studies at least, they're going to be tested at 3 months, they're going to be tested 6 months, 12 months. At 12 months out, they still have high antibody levels. We'll say great. In the lab, they can take those antibodies and take the virus. They can see, is the antibody still killing the virus? As new strains come out, they'll look and see, oh no, now there's a mutant that our spike protein antibody is no longer killing, or that we need to change it a little bit to do that. And the third is just the rates, right? If infection rates start going up, even though lots of people have gotten the vaccine, then that's a sign that maybe something else needs to be done. So it's a combination of all of those things that will help us figure this out. But mainly it's time, right? Over time, we'll learn more. And that's the best way we'll be able to figure out when we'll need the tweaked booster.
Thank you.
Ron Weinger?
Yes, I think you just answered my question, but I'd just like to make a statement on availability. If any Berkeley Heights resident hasn't responded to the registration emails from the town administrator for the to obtain the vaccine, please do so. It's very important. And if you didn't get one, drop me an email and I will forward the one I got. It's an extra registration that is just for Berkeley Heights residents. It's a town-only thing, but every registration you can get on is going to help.
I'll second that. Register everywhere possible.
Okay, it's
Can I ask a
11:30. Dr. Parikh, can you stick around for a little while longer?
But yeah, I'm happy to stick around for 10 minutes if you want, if you guys have the time.
We got a lot of questions. Walt Meisner? Walt, you have to unmute.
Yeah, okay, thank you. Thanks for a great talk. You really cut through the BS that the media puts out.
No
So
problem.
I really like the conciseness of all the information.
Haven't even figured this
I
out.
have a question on the mechanism of mRNA viruses. If I understand it correctly, it's in a lipid case and the cell pulls it in. The mRNA gets, it makes these spike proteins. These spike proteins are then on the surface of that cell, and then the immune system attacks that cell and presumably destroys it. Is that correct?
No. So the first part was correct. So the mRNA is a blueprint. It gets absorbed into your cell. The nucleus of the cell is where you normally keep your own DNA. But that the mRNA will activate your mechanism to make spike proteins. The spike proteins are on the surface and actually get into your bloodstream. The antibodies and the T cells and B cells recognize those spike proteins and kind of awaken, but they don't go and destroy your muscle cell per se. They're just activated now so that when you see the full virus coming around, it will go out and destroy it. And there's multiple mechanisms of how it destroys a cell, right? It can attach antibodies, it can get filtered through your spleen. There's natural killer cells that will make the virus explode. But it recognizes the fact that this is your muscle cell just displaying, or your antigen. It's called an antigen presenting cell. So it knows that the antigen presenting cell isn't an enemy. It's just helping you activate your immune system.
Okay. I mean, the reason I asked is because there were some isolated cases where people had neurological problems as a result of the vaccine, and I thought maybe it got expressed in a nerve cell, and that causes more of a problem than a muscle cell.
Yeah, I mean, I don't know the answer, but one of the theories is it's actually what I had mentioned before, is that you've got a lot of viruses like the herpes viruses, right? The ones that cause shingles and chickenpox, they all kind of linger in your nerves. Right? And so one of the theories is that this whole kind of immune activation does something that herpes virus activates and causes those neurologic symptoms that some people are getting. So that's the theory. But again, not enough is known yet.
Okay, thanks very much.
Nolan?
Yeah, a very simple factoid question. You had a pie chart, I believe, early on with 1.121 million New Jersey residents getting a first dose. I couldn't see the part of the chart that said the percentage over age 65 and the percentage over age 80. I'm interested particularly in that, and a few of us might be.
Yeah, let me see if I can quickly look at that. So in terms of, it's 11% of the people who got vaccinated over the age of 80, and 29% are 65 to 79-year-olds, and 27% are 50 to 64-year-olds. So if you talk about 65 and above, it's about 40% of people. 40% of people vaccinated are over the age of 65. Now, I don't know what percent of our New Jersey population is over the age of 65.
Oh, that was the one I was fishing for.
I don't know off the top of my head, sorry. But I can tell you that
how many doses are given to people age 65 plus and 80 plus in New Jersey, the absolute number.
I think that's the number. The actual number. No, you know what? If you just Google New Jersey vaccine data, it's all out there. I can tell you that a higher percentage of the seniors have gotten the vaccine. If you just talk about the percentage of population than younger.
I'm trying to get a fix on that, but thanks a lot anyway.
Yeah, sorry, I don't have an answer for the percentage of the New Jersey age population. a good
Okay,
question.
Rich Jager?
Yes, I am sure many of us are patients of the Summit Medical Group, including myself. When I go to the website, what I read is basically, don't call us, we'll call you. And my question is, how is the Summit Medical Group deciding to prioritize among all its patients?
Yep. Great question. Thanks for asking. So what happened was the day that the state went from first responders and healthcare workers only to everyone over 65 plus high risk conditions, we got, I think, 20,000 phone calls or something, and literally our phone lines crashed. We couldn't call people who needed their chemotherapy, all that stuff. So we realized quickly that there was no way for us to manage incoming calls and ask for people who are eligible to get the vaccine, because there's no way to filter that out. So what we did instead is we used our data analytics. We've taken all of our 650,000 active patients and we've ranked them by risk. And so we've taken into multiple factors of age and race and your chronic conditions and all of that stuff. And because of that, we've tried to come up with a rank order. Obviously, it's not perfect, but based on that, we now have a list of people, and we're now slowly working down that list to try to get the highest risk patients in. And we just figured it's a much more evidence-based way for us to call out and get these people in one by one, rather than having everyone call, because like I said, people can game the system and just say that they have this or that, right? Which is happening in a lot of the mega sites. But having said that, you will see times when you and your neighbor have the same age and the same risk factors, and your neighbor gets called and you don't, because there's so much kind of stuff that goes into the algorithm that there's
Great.
far more people eligible than we have doses, right? We can only call in a couple thousand people a week, and we have hundreds of thousands of people that are high risk. So unfortunately, anyone who doesn't get a call feels that they're being unfairly treated, but it's just a matter of supply and demand, and we're trying to do it as fairly as possible. But there will be people who feel like they've been left out. We're trying to do it as fair as possible. Hope that answers. And thank you for being a patient.
Mike Martin, please.
Yeah, thank you for the call. If there's one statistic that's cited for the vaccines is the 92% effective rate of Moderna and Pfizer. And people are essentially selecting those vaccines if they have a selection. My question is the sample size or the sample demographics went from 16 to 80. So 2 questions. Is the efficacy rate for this group, particularly 65 and older, much lower than 92%? And secondly, does it suggest also, because our immune systems are certainly not as healthy as a 16-year-old, that the duration of the protection is also less? Thank you.
When you look at the subset of data, it does seem to be slightly less effective in people over 65 than people younger than 65. Then they give you the average, like you said, which is in the mid 90s. But having said so, yes, it is a little bit less effective in people over 65. Duration wise, we don't know. Again, if you think about what we know about the immune system, it is possible that immunity wanes more quickly in people over 65 than it does in younger folks, but we don't know the answer to that one. But the one thing that I tried to emphasize that even if you are to get more likely to get sick, I still think that the risk of getting really sick is significantly lower when you get a vaccine. But again, maybe higher if you're 85 than you are 20. So unfortunately, age will play a factor in all of these things in terms of how sick you get or how well the vaccine works.
Thank you.
Okay, because of timing, I'll do one more question.
Right.
George Cole.
Yes, very good talk. My question is about natural immunity. The the Wall Street Journal over the weekend had an editorial about how we're headed towards herd immunity sooner than we think, in that the natural immunity to COVID-19 seems to be higher out there. Is there any way to test for that, or do we just keep following the numbers?
Yeah, like I mentioned, yeah, 30 to 40 million people that we know have had COVID in the US because of positive tests, but likely it's 3 times that many. The only way to really figure this out is if we did mass testing, right? We started testing kind of significant samples in various, to really get a sample across the region, and then to do antibody testing, right? Because you're only going to have the virus in your nose for a couple of days.
But would that show that you have a natural? How do you detect the natural immunity?
So again, I'm not the expert on this, but there are different antibodies that you make. So there's a nucleocapsid antibody that's made that attacks a different part of the virus that you get when you have natural immunity, while you can test for spike protein antibody that you get when you are vaccinated. So you'd have to test for all these different types of antibodies to really get a full picture of how many percent or what percent of our population is immune at this time, which I don't think we have the resources to do on a large scale basis yet.
Thank you.
Great.
Okay, Steve.
Dr. Parikh, thank you so much for providing us with a professional and comprehensive treatment of COVID-19 viruses. In effect, your presentation has really helped us to reduce the number of Rumsfeld unknowns for many of us. And also thank you for taking the time out of your very busy schedule, not only your Chief Quality Officer responsibilities, but also your internal medicine practice. And also a special thank you to Elise Toloni of the Summit CityMD organization. Elise is on the call with us today, and you all should know that in the past 3 years, she has identified 2 outstanding speakers for the old guard. Thank you, Elise.
Thank you, Stephen.
And thank you all for the time. And I apologize that we don't have enough time for all the questions. And again, I apologize if I was speaking too fast. I get very excited about this stuff.
Dr. Parikh, we have 2 ways of thanking our speakers. The first is with a certificate of appreciation, which you can see on the screen now. For our guests, just let me draw your attention to the lower left-hand side of the screen where you'll see an orchid there. And the reason for that is that back in 1930, when the Summit Old Guard was founded, the city of Summit was the epicenter of the orchid growing and distribution industry for orchids in the United States. And so it was natural that our founders would choose the orchid as our symbol and as our logo. We will send a copy of this to you electronically with our thanks. And there's also a second way we have of thanking our speakers. And Joel, if you could unmute everyone just for a second. That is
Everyone can unmute themselves.
Okay, yeah. If you can unmute yourselves for a second, folks. We'd like to provide you with the Summit Old Guard round of applause.
Thank you.
Thank you very much.